Good afternoon, everybody. Today I'll be talking about common abnormalities in the abdomen, and there is considerable more detail in your syllabus, so today we'll be focusing on the images predominantly. And before I get started, I wanted to thank Dr. Wee Chung for his support. So abdominal ultrasound is basically the modality of choice when we're evaluating right upper quadrant pain, gallstones, patient with jaundice and elevated liver enzymes, and patients with elevated creatinine. And it's useful in the multimodality evaluation of many different disease processes, including a surveillance for hepatocellular carcinoma in patients with hepatitis and cirrhosis, cholangioCA, and renal disease. Now, there are different components of the abdominal ultrasound, which have corresponding different CPT codes. The complete abdomen includes the spleen and both kidneys and the aorta IVC and portal vein. The right upper quadrant does not include the spleen or the left kidney, and the renal exam includes the kidneys, the bladder, sometimes we see the prostate, and the aorta. There's a different CPT code for screen versus follow-up. Now I'm showing you this liver cine image of this liver cine images because I think it's very important to incorporate cine images into all of your ultrasound protocols. Many times we see findings on the cine clips that the technologist or ourselves may not have picked up on the static images. So discussing, first of all, parenchymal liver diseases, starting with fatty liver. The most common causes of fatty liver are obesity and drinking too much. And we usually see diffusely increased echogenicity of the liver plus or minus areas of sparing. And in severe cases, we'll see sound beam attenuation and decreased visualization of the vessels in the diaphragm more posteriorly. So here's a case of severe fatty liver where we have an echogenic liver, but as we progress more posteriorly, we lose the sound beam. It basically attenuates. We lose any vascular definition we may have had more proximally, and we really don't see the diaphragm very well. I don't know if the diaphragm is this down here or this up here. Now, fatty sparing and focal fat may mimic liver lesions, and we typically see these around the periportal regions of the left lobe of the liver, the gallbladder fossa, falciform ligament, porta hepatis, and the liver margins. And fatty sparing and focal fat are usually geometric, they're usually not spherical, and if you put your transducer in the opposite plane, it should elongate, so this should help differentiate these entities from a liver mass. One of the other hallmarks is that the hepatic vessels are not displaced. But if you're not confident if what you're seeing is either fatty sparing or focal fat, definitely you can do MRI in these patients. So here's a nice example. This is a sagittal image of the gallbladder with the adjacent liver. We see a triangular hypoechoic focus, and you can confidently call this fatty sparing. It's very angular, very geometric. Here's another case, another sagittal image where we see sort of these elongated foci, hypoechoic foci along the gallbladder fossa. Again, you can confidently call these fatty sparing. Here's another transverse image of the gallbladder where we see sort of a crescentic focus of a crescentic hypoechoic focus. It's not a round mass, it's just kind of following the contour of the gallbladder fossa. Again, fatty sparing. Here's a nice example of focal fat where we see an echogenic focus draping around the vasculature of the liver. It's not displacing the vessels. Hepatitis. Hepatitis without cirrhosis is usually unremarkable by ultrasound. In our literature, traditionally, there's the description of the echogenic portal triads. But because our machines are so good now, this really doesn't hold true anymore because we see the echogenicity of the portal triads normally. But you may see hepatomegaly, heterogeneous liver parenchyma, gallbladder wall thickening, or contraction and periportal adenopathy. Now, cirrhosis is fibrosis and regeneration of the liver, and the most common causes include alcohol and viral hepatitis. And basically, we typically see in more advanced cases heterogeneous liver parenchyma, nodular contour, and ascites. And over time, we'll see increased size of the caudate in the left lobes, followed by an overall decrease of the liver size more remotely. So here's a nice case of advanced cirrhosis in a patient with ascites, where we have a nodular contour of the liver's overall shrunken. We also can see vascular complications of cirrhosis. Here, for example, this is a sagittal image of the right lobe of the liver in a patient with ascites, and we see a large varix. We can also see recanalized paraumbilical veins. In this patient, the blue actually represents fugal flow within the portal vein, and the red actually represents a dilated hepatic artery. So we have reverse flow in the portal vein from portal hypertension. We have many focal liver lesions we can review. We're going to review the most common. Cysts typically have an anechoic lumen, increased through transmission, echogenic back wall, simple cysts. We frequently see septations. Small cysts can be more difficult to discern, so Doppler sometimes can help us if we're trying to decide if this is a small cyst versus a vascular lesion. And the differential for complex cystic lesions includes hematoma, abscess, metastases, and biliary cystadenoma and cystadenocea. So here's a nice example of a large cyst within the right lobe of the liver. It's almost 8 centimeters long. We have the well-defined back wall, we have increased through transmission, anechoic lumen, and a little bit of a septation there. Here's a patient with polycystic kidney disease who has multiple cysts within the liver, so also has polycystic liver. Notice that some of the walls of the cysts are a little bit irregular, and that's okay. And here's a cine images of the same patient. Again, just, anechoic lumen's very, very simple. Easy to call those cysts. Hemangiomas we see commonly, especially in young patients, and the hallmark of hemangiomas is that they're homogeneous, they're hyperechoic, and they have increased through transmission. They're usually less than 3 centimeters and are not associated with increased blood flow. If you see blood flow in a lesion with these characteristics, you may also want to consider metastasis and hepatocellular carcinoma in your differential, especially given the patient's history. And in patients with hepatitis or cirrhosis or other types of liver disease, you may need MRI for further evaluation and characterization. So here's an example of basically a uniformly echogenic lesion. And you may argue there may or may not be some increased through transmission, but in a young patient with no risk factors for liver disease, I'm going to call this hemangioma and move on. I'm not going to follow this patient up. If this patient, however, has HCC or hemochromatosis or some other liver disease, then I'm going to get an MRI for confirmation that this is a hemangioma. Here's another example of a well-defined echogenic lesion within the liver, homogeneous, and no increased blood flow. We call this hemangioma and moved on to the next case. Now this is a bit of a busy slide, but this is to illustrate the importance of recognizing potential foci of hepatocellular carcinoma. The biggest risk factors are hepatitis and cirrhosis. Now the HCC can be very variable in its appearance on ultrasound and MR. It can be solitary, it can be multifocal, or it can be infiltrating. And these infiltrating types are very often difficult to see by ultrasound or MRI. It can have variable echogenicity, and it also can be uniformly hypoechoic, like I said, like hemangiomas. They also can contain focal fat. Now HCC, if there's vascular involvement, actually tends to invade the portal vein versus cholangiocarcinoma, which tends to compress the portal vein. And if you see portal vein involvement, then make sure to apply your Doppler to look for neovascularity that would occur in tumor thrombus. But you must do an MRI if you detect a lesion in a hepatitis or cirrhosis patient. These lesions are malignant until otherwise proven. So here's a nice example of a hypoechoic lesion within the right lobe of the liver, patient with ascites. This patient had hepatitis. We have increased blood flow associated with this lesion. So this to me is HCC until otherwise proven, and I would get MRI for confirmation. Now here's a nice example of a patient we did experimentally with some ultrasound contrast. In the early phase there was hyperenhancement like there is on MRI. In the more delayed phase it washed out with a little bit of residual enhancement of the capsule, another HCC in this patient. Here's HCC with MRI correlation, hypoechoic lesion within the liver. No increased vascularity in this case. And the MR image of the inferior right lobe demonstrates some subtle hyperenhancement in the early phase. And there's some washout in the delayed phase. So this was confirmed hepatocellular carcinoma. Now metastases are the most common solid liver lesion, usually from a GI primary, but lung and breast are other common primaries we see METs within the liver. METs are usually hypoechoic, but can have a highly variable appearance. And if we want to look for METs in patients, we usually do CT. However, MRI and or biopsy may be helpful in patients who also have hepatitis or cirrhosis. So this is a patient with multiple metastases in the liver, and sort of the more you look, the more you see. And this lesion, for example, is pretty isoechoic to the liver with a hypoechoic rim. This lesion is heterogeneous. This lesion is diffusely hypoechoic. So as you can see, in the same patient with colon cancer, we can have considerable variability in the appearance of metastasis. Now, liver abscesses we don't see very often, but we may be the first individuals to see this because these patients may present with jaundice. So ultrasound may be the first modality to detect a liver abscess. And ultrasound can be used for aspiration to diagnose the organism or drainage, and for follow-up during and after treatment. And differentials include hemorrhagic cysts, hematomas, and necrotic and cystic neoplasms. So this is a patient, this is the right lobe of the liver, so this is a patient who has a large, complex hypoechoic lesion. Doppler did not really add anything to this case. We have diffusely increased through transmission, so this is not a solid lesion. This was shown to be a liver abscess in a patient who also was very sick. Now, in this patient, in this right lobe of the liver, we see multiple sort of echogenic foci with some ring down and some dirty shadowing. This is the hallmark of air. So air can be echogenic with this dirty shadowing, not the clean shadowing we typically see with stones, and some ring down, sort of the white that sort of keeps going down. And when we had MR correlation of this is the T1 post-contrast axial image. We see areas of signal void which correspond to the air, and we see sort of this hypo-intense focus which is consistent of debris and fluid. Confirmation of the abscess. This is just to illustrate the multimodality approach to abscesses. This patient was drained under CT, and here's a large abscess, hypodense collection, foci of air, enhancing capsule, and a coil drainage catheter. Just a cute little granuloma with some posterior shadowing in a patient with sarcoid. We frequently see granulomas, but when they're tiny, we will not usually see this little focus of shadowing. Moving on to the gallbladder. Gallstones are probably the most common reason why we do right upper quadrant ultrasound. Gallstones are intraluminal, they move, they're echogenic, and they shadow. However, stones less than 5 millimeters may not shadow. The differential includes polyps, which do not move, and intraluminal cholesterol crystals, which can mimic floating stones. So here's a patient, this is a sagittal image of the gallbladder, which shows a gallstone with dense posterior acoustic shadowing. And here's another image of the gallstone, which has migrated down towards the gallbladder neck. Just like Dr. Vosi mentioned, it's very important to look at the gallbladder neck. Now here's a patient who has a stone-filled gallbladder. The West complex refers to the echogenic wall that we see of the gallbladder. Then we have the echogenic sort of top layer of the gallstones with the dense posterior acoustic shadowing. So this is wall, echo, shadow, stone-filled gallbladder. Sometimes, however, the echogenic wall and the echogenicity of the stones may be combined. So you may have just a single echogenic line showing you the wall and the echo with just the shadow. Now, sludge can have variable echogenicity, and it usually layers dependently. Tumefactive sludge can mimic stones, but it still should move. So again, mobility will help distinguish this from polyps or tumors. So here's a sagittal image of the gallbladder in which we sort of see, polypoid echogenicity. We don't know whether this is a lesion or whether this is sludge. So then we move the patient, and where did the sludge go? It's up here. We put the patient prone. And here you can see the morphology of the sludge changed a little bit. It did not stay constant, so we knew that this was sludge and not a lesion. Now, acute cholecystitis typically represents about 5% of ER visits, and it's obstruction of the cystic duct or the gallbladder neck by a stone, and the hallmark, gallstones, gallbladder wall thickening, pericholecystic fluid, and sonographic Murphy sign. However, in elderly patients and patients who've been on analgesics, the sonographic Murphy sign may be negative. 5% of acute cholecystitis is actually a calculus, and complications include perforation and gangrenous and emphysematous cholecystitis. So here's a sagittal image of the gallbladder. This shows a gallstone with some partial shadowing, and we have a thickened wall. This patient came in with a typical clinical history and a positive sonographic Murphy sign. This is acute cholecystitis. Here's another patient, a sagittal image of the gallbladder, thickened gallbladder wall. We have a little bit of pericholecystic fluid here. Transversely, when we imaged the patient, we saw the stone. Again, we saw more pericholecystic fluid. Here's another patient, a sagittal image of the gallbladder with some pericholecystic fluid. And this can sometimes be hard, especially in patients with ascites. You don't know if this is maybe some loculated ascites, whether it's pericholecystic fluid. But remember that this can actually indicate gallbladder wall perforation. So it's important to correlate this with your clinical history and other findings in the ultrasound. Just another example. This is another nice example of acute cholecystitis where we see multiple echogenic gallstones and some shadowing. We see some hyperemia of the gallbladder wall and some edema of the gallbladder wall. And we also have the cine images to show that. to show the mobility of the stones as well. Now, acalculous cholecystitis typically occurs in sick or post-op patients due to trauma, sepsis, or ischemia. The secondary signs of cholecystitis can be helpful when trying to decide if you actually have acalculous cholecystitis, but they're not always specific. And HIDA scan can be helpful, however, it can also give you false positive results. So here is a patient who presented with signs and symptoms of acute cholecystitis. We saw a thickened gallbladder wall, maybe a little bit of pericholecystic fluid, but no stones. We still call this acute acalculous cholecystitis. Here's another sagittal image of the gallbladder, which shows marked gallbladder wall edema. Again, typical clinical history. This was called acalculous cholecystitis. Now, gangrenous cholecystitis is more rarely seen. It's due to the sloughing of the membranes and blood in the gallbladder lumen from severe, prolonged, or infected acute cholecystitis. Sonographic Murphy sign is usually negative because of necrosis of the nerve supply, and it's important to look for wall perforation in these patients. So here's an image of the gallbladder in a patient with ascites, and all of this is just basically necrotic, sloughed off membrane, some hemorrhage within the gallbladder lumen. Now, emphysematous cholecystitis is a surgical emergency, can be rapidly progressive and fatal, and it usually occurs in diabetics and may occur with acalculous cholecystitis. And we typically see gas within the wall, plus minus the lumen, and CT can help you with the diagnosis if you're unsure. So here's a sagittal image of the gallbladder in which we see sort of echogenic foci all along the wall. There's a little bit of ring down, so you may not be sure, is this air or is this adenomyomatosis? Here we also see a gallstone. So we CT'd this patient, and this patient had air within the gallbladder wall and a lot of air within the lumen, actually more than we would expect with typical biliary intervention. We also happen to have a plain film in this patient. Supine plain film of the abdomen, again, illustrates the air within the wall, and upright plain film demonstrates the air fluid level. So in my opinion, this patient had the perfect three-part physical exam: the X-ray, the CT, and the ultrasound. No other clinical exam necessary. Other causes of gallbladder wall thickening include chronic cholecystitis, volume overload, inflammatory or infectious processes such as hepatitis, and adenomyomatosis, in which we would see comet tail artifact, usually along the near wall of the gallbladder, just like we just saw in the emphysematous cholecystitis case. And that's due to the cholesterol crystals in the Rokitansky-Aschoff sinuses, and that's basically invagination of the mucosal layer into the muscular layer of the gallbladder wall. And this can present as diffuse focal wall thickening or a fundal mass. So here's a patient who has diffuse thickening of the gallbladder wall, and it looks like it's cloned itself right here. But this is actually edema within the bowel, adjacent bowel wall, and this patient has a considerable ascites. Here's a sagittal image of the gallbladder in which we see several shadowing gallstones, but what is this focus up here? So we do another image of it, and we see some shadowing, we may see some ring down, and we applied some color Doppler to it, and we see some twinkle artifact. Now, twinkle is color artifact that's not arterial or venous. It's basically just an artifact that we get with color Doppler, and it can help us distinguish stones and adenomyomatosis from other etiologies. So the cine images depict the stones very nicely, in addition to sort of this echogenic focus within the fundus of the gallbladder that has some ring down and some shadowing. And again, we do the color imaging, and we see twinkle artifact, which by Doppler proves not to be arterial or venous. Here's another case of basically gallbladder filled with adenomyomatosis. Here's the gallbladder. It's just filled with multiple echogenic foci, lots of ring down artifact, adenomyomatosis filling the gallbladder. Now, polyps, gallbladder polyps, cholesterol polyps are the most common type. They do not shadow and they are not mobile. And the management, basically, nobody really cares about polyps less than 5 millimeters. We don't follow these patients up. Polyps 5 to 10 millimeters, it's variable. Some radiologists don't follow these patients up. A lot of us will follow the patient up once, maybe in like 6 months, to make sure that the polyp is stable. However, if you see a polyp that's greater than 1 centimeter, you should send the patient for surgical consultation, because they may opt to operate or have a more stringent follow-up regimen. So here's a sagittal image of the gallbladder, which nicely shows a polypoid polyp adherent to the gallbladder lumen. This was over 1 centimeter, and this patient was sent for surgical evaluation. Here's another example where we barely even see the polyp. We see a little bit of ring down artifact. This is not a case that we would follow. And here's a tiny polyp adherent to the near wall of the gallbladder. Again, does not layer dependently, does not move, so we know that that's a polyp. Now, porcelain gallbladder is basically a calcified wall with dense posterior shadowing, and a stone-filled gallbladder can mimic the same appearance, as can emphysematous cholecystitis. And basically, CT is important in these patients to evaluate the extent of calcification and to look for possible masses, since there's an increased association with cancer. So here's an example of a patient where this is the top of the gallbladder. The wall is calcified. We see the echogenic wall with dense posterior acoustic shadowing. Patient happens to have ascites. And this is the same patient we saw previously, stone-filled gallbladder. It's really hard to differentiate the two. So we did a CT scan on this patient coming up, and this is just a cine image just showing again the dense shadowing. So our CT scan, the axial view, shows sort of irregular calcification along the gallbladder wall. Now, a few images up, however, we see multiple stones within the gallbladder. So this patient had a porcelain gallbladder and a stone-filled gallbladder. And this is just to illustrate the point that our patients typically don't have just one finding. You typically will have multiple findings in a patient. So just because you see one thing, don't stop looking for other abnormalities. Now, gallbladder carcinoma we don't see very often. It can have a variable appearance. It can be a focal soft tissue mass, focal or diffuse wall thickening. It can be a polypoid intraluminal mass. Tumefactive sludge can mimic it, adenomyomatosis, polyps, and again, increased risk with porcelain gallbladder. So here's a patient with a large intraluminal mass filling the gallbladder. This is gallbladder carcinoma. Moving on to the biliary tree. So when we're evaluating these patients under ultrasound, we're looking for causes of biliary obstruction in patients with jaundice. That's our role as sonographers, or sonologists, I should say, as well. One of the most common causes is choledocholithiasis, stones in the common duct, and these usually occur in the more distal or intrapancreatic portion of the duct. It can be due to tumors, other causes such as inflammation and infection, and we may need MRCP or ERCP for further evaluation. So here's a patient who had considerable intrahepatic biliary dilatation, and we went further down and we see this considerable dilatation of the common duct, 1.7 centimeters. So we go further down, we continue to see distension or dilatation of the common duct, and we see a stone distally in the region of the pancreatic head. So we figured out the etiology for all the intrahepatic biliary dilatation. Now, pneumobilia usually occurs from prior biliary intervention. It's air within the biliary tree. We see bright echogenic linear foci along the portal triads, and we may see some posterior dirty shadowing or ring down artifact like we saw previously. And basically the air bubbles will move with position change. So here's a patient with pneumobilia. This is the liver, and we see sort of multiple echogenic foci sort of branching throughout the liver. And again, when the patient's position changed, the appearance of the echogenic foci also changed. This patient had had prior biliary intervention. Even though Dr. Voci went over the normal pancreas, I just want to illustrate again the importance of knowing your midline anatomy. We frequently see abnormalities in the midline without necessarily seeing the pancreas. We want to make sure where these abnormalities are. And again, knowing your vascular landmarks is actually critical to sometimes assessing a midline abdominal pathology that is either expected or unexpected by ultrasound. For acute pancreatitis, we don't use ultrasound for evaluation. We usually use CT if they need evaluation in addition to clinical evaluation. However, we use ultrasound to evaluate the biliary tract and for possible stones, as in gallstone pancreatitis. And if we see the pancreas by ultrasound, it may be diffusely or focally enlarged with a decreased echogenicity. But we also want to look for peripancreatic fluid, pseudocyst formation, causes of biliary obstruction, pancreatic abscess, and vascular complications. So here's a midline transverse view of the abdomen, which shows an enlarged, boggy, hypoechoic pancreas. Again, notice your vascular landmarks. This patient had acute pancreatitis. Now this is another transverse midline image. We don't really see the pancreas, but we see this large, complex fluid collection, lots of debris. We have our vascular landmarks. This was a pancreatic pseudocyst. Now, in chronic pancreatitis, we typically see calcifications that are intraductal. The duct is usually dilated. It can be diffusely dilated. It can have a beaded appearance or a tortuous appearance. And we may see alternating areas of like enlargement and atrophy of the pancreas from repeated scarring, alternating with edema and inflammation. So here's a patient in whom we see the pancreas, we see multiple echogenic foci consistent with calcification, and we see a beaded sort of tortuous pancreatic duct. Now, pancreatic cancer, again, with ultrasound, we don't typically image for pancreatic cancer, but we may be the first to incidentally see this in patients with jaundice. And we can see ductal dilatation proximal to the tumor. The double duct sign refers to dilatation of the pancreatic and common ducts, which we can also sometimes see with chronic pancreatitis. We may have pancreatic atrophy distal to the tumor. And one of the pitfalls, just to keep in mind, is an accessory spleen may mimic a pancreatic mass. So if you see an echogenic mass within the pancreatic tail, think accessory spleen, and this can be confirmed a lot of times with the nuclear medicine red blood cell study. So here's a patient with ill-defined hypoechoic mass within the pancreatic head. So this was incidentally noted, this is in a patient with jaundice, pancreatic carcinoma, further evaluation with CT. So here's another patient with a large mass within the pancreatic head, very heterogeneous. So we see the mass, but then we also looked for ductal dilatation, excuse me. So here we have dilatation of the pancreatic duct up to close to 6 millimeters. Cine images depicting the mass with the ductal dilatation across the top. Now, splenomegaly, there are many causes of splenomegaly. Typically, we see splenomegaly in patients with portal hypertension. It can occur in patients with infection or hematologic malignancies, infiltrative processes. So there are many causes. You may also have splenomegaly with associated focal lesions in patients with lymphoma metastases. So here's a patient with splenomegaly. This is a patient with portal hypertension. We see a 14-centimeter spleen, but note that the spleen usually retains its same smooth echogenicity, very homogeneous. Another patient with portal hypertension, enlarged spleen, but it's maintaining its crescentic shape and a homogeneous echogenicity. Now, splenic cysts, we say cyst versus pseudocyst in our reports, and we usually move on. And usually these are actually pseudocysts, not actual true cysts. And these are from hematomas that have evolved into seromas. They don't have a cellular lining, and they may have sort of a complex appearance with calcifications and internal debris. Epidermoid cysts or true cysts are actually rare. And other etiologies for splenic cysts include infectious cysts, pancreatic pseudocysts that have eroded into the spleen, and sometimes vascular lesions can mimic cysts. So again, remember to use Doppler to differentiate vascular lesions from cystic lesions. So here's a patient, a longitudinal image of the spleen. Here's a patient with a hypoechoic lesion within the spleen, somewhat irregular margins, but we have some increase through transmission, no increased Doppler flow. We call this a cyst versus pseudocyst. Now here's a patient with a complex cystic lesion within the spleen, lots of debris, diffusely increased through transmission. This patient was sick. This was a splenic abscess. Now, solid splenic lesions are frequently nonspecific, and you need correlation with the clinical history or other findings on the scan to be able to determine what they are. We typically see in the spleen hemangiomas or lymphangiomas, which are hyperechoic and homogeneous, just like hemangiomas are within the liver. Hypoechoic lesions tend to represent more ominous etiologies, such as lymphoma or leukemia or metastasis, and they may be unifocal, multifocal, or diffuse. Mets with the spleen are rare, and lung is what I most frequently seen in the spleen, but lung, breast, colon, melanoma, these can all be etiologies of splenic metastasis. And other lesions include infarcts, infection, and more rare cases, sarcoid and extramedullary hematopoiesis. So this is a patient who has a uniformly hyperechoic lesion within the spleen. We call this likely splenic hemangioma. We put color on it and really not much increased flow. So, a patient with no risk factors, no history of malignancy, likely hemangioma, and that's okay. Now here's a patient with non-small cell lung cancer in which we see multiple heterogeneous foci within the spleen, multiple heterogeneous appearing lesions. So this is a nice appearance of metastatic disease. We also incidentally picked up an adrenal mass, which was a metastasis. And again, the cine images, which nicely depict a very heterogeneous appearance of metastasis within the spleen. Just miscellaneous spleen. Splenials we see very frequently in individuals. Most of the time we can tell they're splenials because they look exactly like the spleen. They're just smaller, maybe a little bit more round. However, if you're not sure, you can do a nuclear medicine tagged red blood cell study to confirm the diagnosis. If you don't see the spleen in the left upper quadrant, in the super rare case, it may be wandering. It may be somewhere else in the abdomen. If the spleen is absent, it could be due to sickle cell disease. It could be due to congenital asplenia. If you see multiple spleens, it also may be a congenital finding. And other lesions in the spleen we can see include lacerations and hematomas. So here's a patient post-motor vehicle collision in whom we see sort of a branching sort of hypoechoic foci within the spleen surrounding this hematoma. Incidentally saw a pleural effusion. Transverse image of the same patient, again the same finding. So we know that this is a local focal lesion with some surrounding hypoechoic foci, which was the laceration. And here we see the branching pattern of the vascularity extending into the spleen. And the cine images of the patient nicely depict sort of branching pattern of the laceration within the spleen and the focal hematoma. And on the cross-sectional image on the CT, we see the splenic lacerations, also see a liver laceration. Moving on to the kidney. In the kidney, we frequently may confuse this with dilated renal pelvis, and this is the left kidney, so I'm actually trying to show you a dromedary hump here. But remember to apply your Doppler, because a lot of times these hypoechoic foci that look like pelviectasis or mild hydronephrosis in the kidney are actually just blood vessels. And again, a dromedary hump would have normal flow, vascular flow. The flow would not be displaced around it or would not be disorganized. Here's another example of a junctional cleft, just a little bit different from the one that Dr. Vosi showed earlier. This is not a duplicated collecting system. We see the full renal sinus fat that's not interrupted. Now, congenital anomalies of the kidneys we frequently can see, and depending on the type of institution you're at, especially if you do a lot of peds. Horseshoe kidney, this is connection of the right and left kidney across the midline. And we have a nice cine images to depict that. This is not midline adenopathy. This is solid tissue, parenchymal tissue, attaching the right kidney to the left kidney across the midline, and we see the aorta and the IVC behind that. This is a patient with multicystic dysplastic kidney, and we have the cine images of this patient. We see very little renal parenchyma, if any. And these patients can sometimes present with renal failure, and we may be imaging them because of renal failure. Now, hydronephrosis, the hallmark of hydronephrosis is that this is collecting system dilatation that communicates with the renal pelvis. And I try and make it easy. Mild is just dilatation of the renal pelvis. Moderate, the pelvis plus the infundibula. Severe, the pelvis plus the infundibula plus the calyces. So just sort of in this pattern. Sometimes the differentiation between mild and moderate severe is difficult. That's okay as long as you're in the ballpark. And remember, if you see hydronephrosis, have the patient void. Look at the bladder, have the patient void if the bladder's full. Or you may actually find a lesion in the bladder. So most obstructive lesions are from the pelvis, so always look at the bladder in these patients. So here's a case of mild hydronephrosis. This is a sagittal image of the right kidney in where we see dilatation of the renal pelvis. There's separation of actually the renal sinus fat. Here's a patient with more moderate, possibly moderate to severe hydronephrosis where we see more considerable dilatation of the renal pelvis extending to the infundibula. And although the calyces are mildly dilated, they still maintain their cupped or chalice shape. They're not ballooned or blunted. So you could call this moderate or moderate to severe. And here are the cine images which show you that all of this connects. The dilatation connects all the way through to the renal pelvis and the proximal ureter. This is a patient with severe hydronephrosis. This is a sagittal image of the kidney. And note that there is blunting of the calyces. You don't have the nice cupped or chalice shape. These are blunted calyces. This is severe hydronephrosis. Now, what are we going to do? We're going to look at the bladder. Now, in the bladder, we only see the left ureteral jet. We don't see the right. So there may be something along the right urinary tract that's obstructing the right kidney. So then we can focus our clinical evaluation based on that. Here's another patient with severe hydronephrosis. Again, dilated calyces, which are blunted. We have dilatation of the infundibula and the pelvis. This is also the right kidney. We looked at the bladder, and we saw a large mass within the bladder. A little bit of increased flow within that mass. And here are the cine images to show that this is sort of central, a little bit more eccentric to the right, obstructing the right renal collecting system. This is a patient with an obstructed upper pole moiety, and this only shows you, this is a longitudinal image of the right kidney, so it only really shows you partially. But when you look at the cine images, this is scrolling superiorly to inferiorly. So superiorly, you see the dilatation of the entire collecting system, and inferiorly, it's normal. So this obstructed upper pole moiety. Now, renal stones, we do ultrasound basically sometimes to confirm the diagnosis, because we really don't want to keep radiating patients just for renal stones. And typically what we want to do by ultrasound is see if there is a stone, see how many there are, how big they are, and are there associated complications? Is there hydronephrosis? Is there perinephric fluid? Are there calculi anywhere else that we can see? And try and hydrate these patients well to distend their ureters, distend the bladder. You may have improved visualization, and always assess for bladder jets, because the bladder jet, you may not see if there's a stone obstructing the ureter. Findings of stones. Stones are, they're non-mobile, so usually fixed within the kidney, but they may or may not have shadowing depending on their size. And also we will see frequently twinkle artifact, like I mentioned before, the artifactual color flow that we get that's not vascular, not arterial or venous. And this can help us distinguish this from calcified vessels, which can mimic stones. So here's a transverse image of the left kidney, which shows a large stone within the collecting system and some ring down, some shadowing. Some shadowing. And there's twinkle artifact on this, and there's also twinkle artifact involving the shadowing as well. So a nice example of calcification with a twinkle artifact. Now, renal cysts, just like lesions in the thyroid, almost everyone has a renal cyst. Over half of the population by the age of 50. Cysts can be anywhere, cortical, parapelvic, or medullary. Again, anechoic, well-defined back wall, posterior acoustic enhancement. But it's important to note in the kidney that you should really not see a wall, especially against the renal cortex. You really should not be seeing a wall. And if you see a wall, if you think it might be thickened, this will prompt further evaluation. And small cysts are very difficult sometimes to determine by ultrasound. We're not good at determining what lesions are that are less than 2 centimeters very frequently, especially less than 1 centimeter. And you may have internal echoes in these cysts from hemorrhage or debris. And it's important when you look at a cyst, assess for the internal echoes, assess for the septations, calcifications. Is there a thickened wall? Is there muronodularity? These are all very important things to assess for. Here's a patient who has multiple parapelvic cysts, and you may wonder, well, why isn't this hydronephrosis? Well, these cysts do not connect with the collecting system. This is a sagittal view, and this is the transverse view. And here we have the cine images showing we have multiple parapelvic cysts, but none of them connect with the renal pelvis. So this is not hydronephrosis. It doesn't have the nice branching pattern that we saw with the hydronephrosis with the dilated infundibula. Now, complex renal cysts, there are several ways to manage complex renal cysts. Cysts that you may not need to follow or maybe just do a one-time follow-up for. These are cysts that would just have maybe a few septations. Few means 2 or 3. Calcification, if you see it, should be thin, curvilinear, or like very peripheral along the cyst. Sometimes you may see some milk of calcium, and cysts that may have internal echoes from a hemorrhage or debris. These are cysts that you may not need to follow, but if you're not confident, doing a follow-up in 3 or 6 months is reasonable. However, you should consider doing CT or MRI pre and post contrast for cysts that have a thickened wall or muronodularity, multiple thick, calcified, or hypervascular septations, amorphous or central calcification, or if you just simply can't characterize it in any way, you can't see it completely. And remember, always use Doppler to characterize lesions. So here are 2 patients with hemorrhagic renal cysts. This cyst is basically very complex, multiple internal echoes, diffusely increased through transmission, no increased Doppler flow. This was a hemorrhagic renal cyst. And again, confirmation with CT or MRI. Here's another patient with a hemorrhagic renal cyst. Down here posteriorly, we see the renal cyst, septation, some debris, partially anechoic, diffusely increased through transmission, little bit of dilatation in the adjacent collecting system. This is a patient with simple and hemorrhagic renal cysts. If you look at the images, you'll see several simple cysts followed by a hemorrhagic cyst with internal debris. And we have a still image of that hemorrhagic cyst with some internal debris. Now, calcified renal cysts we see also very commonly. Here we have calcification with some shadowing. Here's another patient with a calcified renal cyst. We see the echogenic line consistent with the calcification with some shadowing. And now we have a calcified hemorrhagic renal cyst. We have all the findings. So we have a mass that has fluid levels in it, partially anechoic, some layering fluid. We have calcification along the wall. We have some increased through transmission. And just what a nice comparison for us, incidentally noted, is a simple cyst right next to it. And here are the cine images depicting the shadowing from the calcification of the hemorrhagic renal cyst. Now for this patient, depending on your level of confidence, again, following this patient up with CT would be great because of the calcification, but you could also comfortably call this a calcified hemorrhagic renal cyst, especially since there's no increased Doppler flow. Now polycystic kidney disease, the hallmark of polycystic kidney disease is enlarged kidneys with multiple cortical and medullary cysts without normal intervening renal parenchyma. Early on in the disease process, in patients under the age of 30, you may see normal renal parenchyma, but as these patients age, you should not see normal renal parenchyma. And basically, we use ultrasound in these patients to identify other sites of cysts, such as the liver or the pancreas, to screen family members, and also to follow up the cysts. And basically, we should use the same criteria for individual renal cyst evaluation for each of these cysts within the polycystic kidneys. It can be very, very cumbersome. And just remember that hemorrhage is common in PCKD, and so following these lesions up in 3 to 6 months for regression is actually very reasonable before progressing to other cross-sectional imaging modalities such as CT, which would increase the radiation. Now here's a patient with polycystic kidney disease, multiple cysts within the liver, not much really intervening renal parenchyma. I'm sorry, I said liver, I meant kidney. And the kidney was actually enlarged. It was about 16 centimeters. Now, acquired cystic kidney disease is usually due to dialysis, long-term dialysis. Most patients have this after 5 years, and there is an increased incidence of renal cell carcinoma. And the hallmark appearance, small echogenic kidneys with multiple small cysts. And again, just like PCKD, hemorrhage in these cysts is common. So if you see a complex cyst, it's okay to follow the cyst up in 3 months to see if it's stable or if it has regressed in size. So here we see the liver very nicely, but where's the kidney? It's hiding in the background of the fat. And here we have the cine images, which you can a little bit more easily see the kidney, but you really better see the cysts that are within that kidney. So these kidneys are often very difficult to see. Now, renal cell carcinoma, all solid renal masses, in my opinion, are renal cell carcinoma until you prove them otherwise. If I see a solid mass in a kidney, I'm calling it renal cell carcinoma, even though there's an up to 10, 20, 30% chance it could be benign depending on what literature you read. So if you see a suspicious renal lesion, we're going to work up that patient with CT and sometimes with MRI, but ultrasound tells us many important things. So just because we see it doesn't mean we stop. We should still try and characterize it as much as possible. Is the lesion, how big is it? Is it solid? Is it cystic? Are there septations? Is there calcification? Is there necrosis? What about the vascularity of the lesion or of the septations? Is there mural nodularity? Are there other lesions in the kidney? 10% of renal cells have another lesion in the same kidney. 1%, there's a contralateral renal cell carcinoma. Are there any lesions in the liver? Do we incidentally see adrenal lesions, adenopathy? And we have to assess for the vascular patency. Is the renal vein patent? Is the IVC patent? And remember that a hypertrophied column of Bertine or dromedary hump can mimic a renal mass, especially in the left kidney. So don't fall for that trick. Again, apply your Doppler. So here's a patient with what I call a well-behaved renal cell carcinoma. We have a homogeneous, mildly hyperechoic mass. And you may say, well, there looks like there's some increase through transmission. Renal cells can have that sometimes because they may have multiple tiny, tiny cysts in them. And we applied some Doppler to this. We see some increased flow. And this to me is a renal cell until proven otherwise. Here's the cine images, which nicely depict the flow within the lesion. And the coronal CT images, which shows a heterogeneously enhancing mass within the right kidney. Now this is not a well-behaved renal cell carcinoma. This is a mass infiltrating the right kidney, basically. I can't tell what's normal renal cortex and what's mass, and the margins are very irregular. And so we applied Doppler, And this is the transverse image of that same kidney. And here, this is the right renal vein. And this is all thrombus, tumor thrombus filling the right renal vein. So next we assess the IVC, and we see soft tissue within the IVC. And when we apply Doppler, we saw that there is flow. So this was tumor thrombus extending into the renal vein and into the IVC. And the cine images of the kidney show this mass infiltrating the right kidney. And you see a little bit of normal cortex in the near field, but the rest of it is really difficult to discern. Now, angiomyolipomas are typically echogenic lesions that are either in the renal cortex or they're exophytic, and they're similar in echogenicity to the renal sinus fat. My experience has been that these are more typically cortical rather than exophytic, and that may help sometimes in differentiating them from renal cell carcinoma. However, if they're lipid poor or hemorrhagic, they may be hypoechoic, and this makes basically a diagnostic conundrum for us. We really don't know what to do with these, and in some patients, this prompts obviously further evaluation with CT or MRI to look for focal fat, but also may be an indication for biopsy in some patients. And we can look for focal fat on CT like we're traditionally taught to, but remember that a small percentage of renal cells can also contain focal fat. So again, just be aware of that pitfall. And we worry about renal angiomyolipomas when they exceed 4 centimeters because there's an increased risk of hemorrhage. This is a patient with tuberous sclerosis who has multiple echogenic lesions, predominantly cortical. These are multiple AMLs in a patient with tuberous sclerosis. And the cine images, again showing the same thing, just innumerable AMLs in the right kidney. Now, transitional cell carcinoma, as we all know, this typically occurs in the bladder. However, if it does occur in the kidney, we may see peripelvic, parenchymal, and infiltrative extension. We may see chaliectasis. Blood clots are the most common mimicker. And if we suspect transitional cell carcinoma, of course, we're going to recommend a CT urogram. And the patient also needs urologic evaluation with cystoscopy and ureteroscopy. So here's a transverse image of the kidney depicting a dilated renal pelvis with soft tissue in it, and also there's some chaliectasis. And this was either some soft tissue or some hemorrhage within that calyx. This was transitional cell. Now, other renal masses include oncocytoma, lymphoma, Mets, and PTLD. And oncocytomas, imaging-wise, you really can't tell from renal cell carcinomas. There's more and more in the literature about biopsying lesions, which is beyond the scope of this talk. But lymphoma is also rare, but it can be focal or infiltrative. Metastases, you usually cannot distinguish these from renal cell carcinoma. However, if there's a patient with, say, a primary lung cancer who also has a solid renal lesion, in my opinion, that's still a renal cell carcinoma until we prove otherwise. And in patients with PTLD, it's very important to recognize this potential diagnosis, because if you diagnose a patient with PTLD, that will affect their immunosuppressive therapy. So this is a patient with renal lymphoma. This is an infiltrating lesion, basically invading the renal sinus and cortex of the right kidney. And you may say, well, are you sure you're not angling in a kind of different way in a young, healthy patient? Let's look at the contralateral kidney. So this is the cortex in the contralateral kidney. We did cine images of this patient, and we see this infiltrating process extending into the renal sinus and the cortex. Now, this is a right lower quadrant transplant kidney. We saw a hypoechoic lesion in this kidney. And we apply, power Doppler. There's really not much increased flow. We're not really sure what this is, but we think it could be PTLD. So this was biopsy-proven PTLD. Again, that changes the immunosuppressive therapy of this patient, so very important to recognize. Renal infection and pyelo, we typically don't image the kidney with ultrasound for pyelo. However, in patients who can't get CT, especially pregnant patients, we use ultrasound to look for complications. Ultrasound is typically normal in pyelo. The findings may be very subtle, and here are many findings that we could potentially see. But the most important thing to look for is to look for error, because if we have emphysematous pyelo, that's a surgical emergency. So here's a patient with pyelonephritis. This is a sagittal image of the right kidney, and the findings are extremely subtle. Here's a transverse image. You may argue there's a little bit of change in the echogenicity in this portion of the kidney with respect to the rest of the cortex. Questionably decreased flow, but again, we're not really that good at it by ultrasound. Here's a patient with HIV. The hallmark of HIV kidneys, enlarged echogenic kidneys bilaterally. So again, this is 15 centimeter kidney, enlarged echogenic kidneys bilaterally. Incidental lesions that we may see by ultrasound, we may see adrenal lesions. Typically these will be adenomas, but sometimes they may be metastases or other types of renal lesions. We can evaluate these with a CT or MRI depending on what we think they might be. Effusions, we saw one earlier, ascites, adenopathy, abscess formation, hernias, and abdominal wall lesions. Here's a patient in whom we saw an adrenal lesion. This is a sagittal image of the right kidney, and here we see a little adrenal lesion. Mets. This is a patient with lymphoma, lymphoid tissue adjacent to the hilum of the liver and the spleen. Retroperitoneal adenopathy, again, notice your landmarks. Insularly noted dilated bowel, patient with abdominal pain. Hernia, abscess in the abdominal wall post-op. Take-home points. So although we use MRI and CT to confirm or further evaluate many ultrasound findings, ultrasound is useful for evaluating many different disease processes and to follow them up and to screen patients. New liver lesions in a patient with Hep C cirrhosis or HCC until proven otherwise. New solid renal lesions represent renal cell carcinoma until proven otherwise. And Cine and Doppler are your friends. Thank you for your attention.